Prostatoperineal fistula as a result of extensive resection and radiochemotherapy associated with a large defect in the presacral space leads to a significant morbidity. We present a 57-year-old patient who was sent to our tertiary referral center for reconstructive urology with an extended prostatoperineal fistula and a large defect in the presacral space after neoadjuvant radiochemotherapy, proctocolectomy and multiple abscesses postoperatively. After entering the presacral space, a large defect of the urethra can be seen. The VCUG presents a large fistula from the urethra to the presacral space. In the first step, we inserted 2 Single-J-Catheters, a suprapubic tube, and applied a local vacuum therapy for cleaning for 12 weeks. The wound has already cleaned by the regular use of a vacuum therapy. By performing this, the presacral space was cleaned, the patient was dry and the extension of the fistula had decreased. After 12 weeks, the fistula had become smaller, so we decided to do a reconstruction. We put the patient in a prone position, closed the fistula transperineally by 6-0 monocryl, running suture and marked the skin incision. We used a nutritive flap first described by Maurice Mimoun in 1989, which is a fasciocutaneous infragluteal flap vascularized by the inferior gluteal artery. After resecting the os coccyx, the flap is incised, leaving a medial edge to the skin to improve the venous drainage of the flap. The dissection is performed subfacially from lateral to the medial aspect on the surface of the gluteus maximus muscle. Mobilization of the wound edges, so a primary closure is possible. Transferring the flap into the defect. Those parts of the flap which will be placed deeply into the presacral space have to be completely deepithelized. The suction drainage is put in place. The wound is closed by subcutaneous running sutures, 3O monocryl, and skin closure by running 3O proline. Postoperatively, the patient is kept in prone position for another 8 days. Single-J and the suprapubic tube were kept in place for another 6 weeks. One year later, the patient is completely dry, voids without residual urine, and the cystoscopy presents a completely epithelized urethra with a small defect of the surrounding tissue, which poses no problem for the patient. A large defect in the prostate or urethra after radiochemotherapy and rectum resection are rare events, but in case they occur, are very difficult to treat. Combining a vacuum therapy, complete urinary drainage, closure of the defect by suture, and the use of pedicled flaps to close the large tissue defect can solve this difficult problem.